and welcome for joining us today for our Personalised Care Northern Cancer Alliance Bitesize Learning event. I'm Claire Doney, I'm the Secondary Care Clinical Lead for Personalised Care. I'm just going to briefly talk to the main slide we've got here, which is explaining personalised care as a golden thread. We believe that personalised care should be threaded through every aspect of cancer care, whether that's talking about timed pathways or rapid diagnostic centres. And we've also entitled our session The Domino Effect, because what we've realised through working closely with personalised care is that every single step enables the next step of personalised care, and everything we do has that knock-on effect, and that's how we're actually going to go through our session today. But we'd like to start out first, if we could have the next slide please, with Karen Gannon, who's actually our Northern Cancer Alliance lay representative for personalised care. I'll hand over to you now. Thanks, Karen.
Hello, I'm Karen Gannon, and as Claire has said, thank you, Claire, I'm the lay rep for the Northern Cancer Alliance and the lay rep on the Personalised Care project team. I would like to talk a little today about what personalised care means to me. Personalised care means people have choice and control over the way their care is planned and delivered. It's based on what matters to them and their individual strengths and needs. The overall aim of personalised care is to identify what is most important to the person for them to achieve a good life and to ensure that the support they receive is designed and coordinated around their desired outcomes. We see this as a golden thread that starts its run in primary care with GP conversations and continues through treatment, providing agreed help and support, linking and pulling all pieces together. As Claire has said, if all of these elements need to be in place and if everyone involved doesn't do their bit, it doesn't work properly. It creates a domino effect which can have a negative impact further down the line. I've been a lay rep for the Northern Cancer Alliance for 2 years and sit on 3 pathway boards, also steering groups and working and project groups. I also sit as the Vice Chair of County Durham and Darlington Foundation Trust Cancer Patient and Carer Group. I first became involved in being the voice of a patient when I became a patient advocate for a breast cancer charity 13 years ago. And being involved in this way made me realise how cathartic this is and how it made me feel empowered. I recognise the impact on me personally of representing patient views and the positive effect on everyone involved, including clinicians, of patients having a voice in how services could be improved. And this made me feel encouraged to get more involved. As a result, I continue to be passionate about patients having a voice and that they are given an opportunity to have a say in their treatment planning. To me, personalised care is all about that patient voice and involvement. Empowering all of our patients with the right level of agreed support to have their say in their treatment is powerful and positive and has benefits to everyone involved. But it has to be the right level that is right for them, and having a good conversation is the start of the golden thread. Now we're going to show you a video from Leslie Smith, Living with and Beyond Cancer Senior Programme Manager, NHS England. Thank you, and I hope you enjoy the rest of the presentations.
Hi, my name's Leslie Smith. I'm the Senior Programme Manager for Living with and Beyond Cancer from NHS Cancer Programme. And I'd like to thank you very much for inviting me to talk at your event today. I apologise that it's by video. I hope it's useful for you. I'm just going to share my slides. So I'm going to talk about personalised care across the cancer pathway from the national perspective. So a little bit of background, as you'd be well aware, the notion of survivorship has been around for a long time now. There's a national cancer survivorship over 10 years ago. Then we had the National Cancer Strategy in 2015, and following that in 2019, the long-term plan. And then the COVID situation this year has obviously required some reprioritisation, but overall this focus on follow-up pathway redesign and personalised care implemented together remains very, very important. And COVID has also seen this growth in virtual support for people affected by cancer, although clearly care needs to be taken about the risk of exacerbating health inequalities if everything goes online. And the specifics about the implementation of the long-term plan the responsibility is with the Cancer Alliances, and I have to say Northern are doing a great job. Thank you very much to all of you who are involved with the rollout of the long-term plan commitments on living with and beyond cancer. We're seeing some great improvements, so thank you very much. So with COVID, there was, as I say, a slight change in emphasis. So there was guidance that came out in August, and we are expecting guidance for next financial year to come out. And the COVID situation has brought greater attention onto the release of capacity through the redesign of follow-up, the need to speed up that process of implementation, and also the importance of self-management so that patients are able to look after themselves more effectively from home. So in the long-term plan on living with and beyond cancer, we have three main elements. Firstly, for absolutely everyone, personalised care. So the deadline for this is in fact next year, so that everyone diagnosed with cancer will have access to personalised care. And that means the personalised care and support plan based on a holistic needs assessment, and that's probably repeated through the pathway. Access to health and wellbeing information support throughout the pathway again. An end of treatment summary or summaries given to the patient and to their GP, and a cancer care review in primary care. And these are, we call the personalised care interventions, and I think many of you will be familiar with them as previously being called the recovery package. So the second component of the long-term plan is personalised stratified follow-up. This is for specific cancers. So breast cancer, the implementation by 2020, prostate and colorectal next year, and other cancers where appropriate by 2023. And that choice, a minimum of 5 more cancers, that choice rests with Cancer Alliances. So this stratified follow-up, this redesign of follow-up, the focus being on moving a proportion of people onto a self-managed follow-up pathway. And the third component is of living with and beyond cancer in the long-term plan is the quality of life survey, and my colleague Alice Simon is going to be talking about that in detail with you as part of the programme. So what's important to understand is the alignment of personalised care across the cancer pathway with the comprehensive model of personalised care which NHS England developed a couple of years ago. And at the very centre of that is that important statement, what matters to me, or that question, what matters to you, when you have a supportive conversation with a patient. And our 4 personalised care interventions, which I mentioned in the previous slide, fit in around this model incredibly well. So the personalised care and support planning matches exactly, and then we have end of treatment summary and the health and wellbeing information support being there to support self-management, and the cancer care review in primary care, again helping with that self-management, but also connecting the person in to wider resources in their community through link workers and social prescribing and so on. And the redesign of follow-up through personalised stratified follow-up. This firstly, just again to emphasise, there's alignment here with a major transformation programme in NHS England, which is the outpatient programme. So not only are we aligned with the personalised care model and that implementation, but also with the outpatient programme, which both of which cover all patients, not just cancer. And the patient-initiated follow-up rollout, which is now being accelerated, aligns completely with our supported self-managed follow-up part of PSFU. So if you come across this term PFU, this is exactly what it means. It's the same thing. We're not trying to do anything different to what we'd already intended with PSFU. And these blue areas show you how personalised care interventions wrap completely around the pathway from diagnosis all the way through. So all of those personalised care interventions and more, for example, the monitoring for side effects, long-term side effects as well, and the management of those, all integrated around that follow-up pathway. So I'd just like to talk you through a few of the resources and support that we provide from the NHS Cancer Programme to help local implementation. So one resource that came out earlier this year is the Health and Wellbeing team self-assessment checklist, and the idea behind this is that it gives teams, you can define the team how you like, is to have a self-review of the kinds of information and support that are being provided to patients from diagnosis and throughout the pathway, different information at different stages, different sources of support, and to provide as comprehensive as possible provision. And that resource is on the Cancer Alliance's workspace. The link is there, but if you don't have access to the Cancer Alliance workspace, please talk to somebody at the Northern Cancer Alliance about gaining access, because you'll find a huge array of useful examples of implementation of all living with and beyond cancer interventions in that workspace. Another resource I'd like to point you to is what's on the Macmillan website. So they have just upgraded their website to cover personalised care in line with our moving on from the recovery package language. The link is there, and we're looking forward very much next year, early next year. We hope the Macmillan will launch their e-learning module on personalised care and support planning and what matters to you. So please do look out for that Macmillan module. We have a handbook on personalised stratified follow-up. This came out early this year. Again, highly recommend. It does focus on breast, prostate and colorectal at the moment, but it would be equally useful for people looking at implementing PSFU and other cancers. We also have undertaken an evaluation study on the implementation of PSFU to get recommendations on how we can improve the rollout into other cancers. And this is also available on the workspace, and some key recommendations in there, including how much we need to accelerate the implementation of remote monitoring systems. Talking of which, digital remote monitoring systems, as I say, absolutely vital for full PSFU implementation, and for these reasons about safety netting and efficiency and timely communication of results. We have an implementation guide which is due out in 2021. So I just finish off, here's some contact details, but I would like to just finish off again with thanking you very much indeed for all of your ongoing work around personalised care and the rollout of personalised stratified follow-up. These interventions are completely interwoven with each other. They're interwoven with the wider ambitions of the NHS around outpatients and personalised care, and I wish you all the best with their future implementation. I'm very sorry I haven't been able to be with you personally on a call to answer questions, but please do contact me with anything that you would like to ask me. Thank you very much.
Okay, so I'd like to say thanks to Karen and Leslie for those great introductions. I think it's been really useful to hear from both a patient's point of view from Karen, and also from Leslie as a national point of view, to see what direction we should all be pulling in. So I'm going to expand on what Leslie's just said there with a brief overview of personalised care and what the session today will actually be covering. But this quote, personalised cancer care means providing patients with access to care and support that meets their individual needs from the moment they receive their cancer diagnosis, so that they can live as full, healthy and active a life as possible. It's from NHS England 2020. And I think this epitomises what it is we're all actually trying to achieve, and the important shift has been that we're doing this from that point of diagnosis. Next slide. This is the overarching personalised care model. This is what we're calling this is how we're addressing this now across all long-term conditions. So in cancer, many people will know that we used to refer to a number of elements of personalised care as a recovery package. But now this overarching model covers everything. It's accepting that a person with cancer will most likely have other comorbidities, maybe on other pathways with other long-term conditions, and it's trying to start to use the same language. And looking at the model here, we've got the whole population across the bottom of the triangle, looking at the, we have a universal offer to all patients, so all patients will have a minimum requirement. And then moving up to some targeted interventions. This is people with long-term physical and mental health conditions that will need more specific, more intense support. And it's on the right hand side, it's quite hard to read this model, I'm afraid, but this says supporting people to build knowledge, skills and confidence and to live well with their health conditions. And then at the top, 5% of people with complex needs. So these are the people that absolutely do need our specialist support and help, but it's still about empowering people, integrating care and reducing planned service use. Next slide, please. So why do we do personalised care? Why as a team are we all so passionate about personalised care? In context, we know it's one of the 5 major practical changes to the NHS that's set out in the long-term plan. But also personalised care is about people having choice and control over the way their care is planned and delivered. It's based on what matters to them as an individual and building on their own strengths and needs. But this can only happen within a system that makes the most of the expertise, capacity and potential of the people, families and communities that we're working with to deliver better outcomes and experiences. So it's about making sure we don't look at a person as a disease, as a tumour type. It's looking at them as an individual. What else have they got going on around them and what's actually going to best support them to get through the treatment journey or whatever it is that they're going to face with us as healthcare teams. Next slide, please. Okay, so our team that we've got today and the team that, like I say, gets very enthusiastic about personalised care. We've already heard from Karen Gannon there, who's our lay representative. There's myself, I'm the secondary care clinical lead, and I'm also the lead cancer nurse for County Durham and Darlington. Then we have Tracy Wilson, who's our end of life project manager, who we're linking in closely and trying to smooth that journey when we're talking about personalised care and make sure that language is the same across the board. We have Kath Jones, who keeps us all held together, who's our Northern Cancer Alliance project lead. And we have Hassan Tahir, who's our primary care clinical lead, who's one of our GPs as well. And I'll actually put those there in the order that we're all going to speak, because we're all going to focus on a slightly different aspect of personalised care for the purposes of today. There are so many areas, but we've each picked an area that we feel we really want to explore, and some of those changes that are happening are quite rapid, so just to try and make sure everybody's up to speed with those. Interwoven through this, we'll also hear from Tina, who's one of our patients who's recently gone through cancer treatment in our area. Due to technical difficulties, we did actually have a video of Tina doing this, but we couldn't upload that. So we've taken a true transcription of Tina's words, and one of our personalised care project managers from within the region will just speak those words when we come to those relevant points. Next slide. So this is a brief overview of our work streams as a whole personalised care team that we're trying to address. So it's quite complex, and we tried to set it out in a way that was a bit easier. So down the side there, we've got components of a patient's journey, and then across the top we've got the elements of personalised care, moving across from health and well-being to holistic needs assessments, treatment summaries, stratified follow-up. We've got through there, that's patient activation measures and frailty. We have cancer care reviews, and also prehabilitation and rehabilitation. The areas we're going to focus on more today are going to be prehabilitation, rehabilitation, personalised stratified follow-up, cancer care reviews, and actually we're going to hear from Tracy from an end-of-life perspective for those patients that might get a best supportive care diagnosis or on a slightly different trajectory. So now we're actually going to hear from Tina, or we'll hear Tina's voice in the next slide, just talk about generally personalised care.
You're going to get the treatment anyway, but you don't want to feel that you're on a conveyor belt. You want to feel that the team really wants to help you. You know, you're not just another number, you're a patient that they really care about. And I did feel like that, I have to say, but I have met some patients that don't feel like that.
Thank you. When I was speaking to Tina and she said those words, it really struck with me, particularly saying you're not just a number, it's that you really do feel cared about, because I do feel confident that all healthcare professionals, anybody involved with patients trying to deliver personalised care, we do care, but it's whether our patients feel like that on the receiving end. And Tina did say she did feel like that, which is positive, but she has met patients that don't, and that's what we're aiming to change. Next slide, please. So when we sat down as a team and tried to work out how we wanted to express personalised care, we realised there were some real golden threads working within personalised care as well. So these are elements that we have to take into account whenever we're looking at each aspect. So there's workforce. We all know there are workforce challenges, but also our workforce is really powerful and one of our most enabling features to deliver personalised care. The shared decision making. So that's making sure at any point when a healthcare professional is having a conversation with a patient, that patient is involved in that decision making. They do know all the choices and they're supported and empowered to make the right decisions. IT systems. For anybody who has involvement with IT systems, I may just leave it there, but we know again they're a great enabler as well as sometimes one of our biggest challenges. Our patient experience. Personalised care and patient experience go hand in hand. We can't have one without the other, and what we're aiming to do with personalised care is improve that patient experience. But in order to do that, we have to hear from our patients as well and learn from their current experiences and how we can move forward with that. Communication, and that's not just our communication with our patients, it's communication between each other, it's education, it's learning from each other, sharing best practice. Equality and diversity. It's the whole principle of personalised care that not any one individual is the same as the next, and we know that of different groups and different areas of our communities, different geographical areas. We have very densely populated city areas in our patch and really rural areas, so that there's all sorts going on there. And a new one we've got in the bottom there, which I'm sure we're all acutely aware of, is COVID is running through and changing the very story of how we're delivering care. But actually there's some really positive things coming out in terms of personalised care due to COVID. So that's we've got to celebrate that as well. Next slide, please. So at the start of this, I'm just going to cover health, wellbeing and information and support as the first part of personalised care. So this is to enable personalised care to be delivered. It's about self-management, patient empowerment and an individual being able to take control. To do that, we need to make sure they have all the right information at the right points when they want it and in a way they would like to receive it. We used to talk about health and wellbeing information and support at the end of treatment, as if that was something that will get them through everything they need, and then we'll tell them about financial support or what other support may be available. We now know we have to do that right from the very start. So that's quite an overarching title, really, because although we offer it at the start, it should be offered at every point throughout the patient journey. But if I can just move on to the next slide, there's one aspect which is perhaps newer to our field of work to be talking about, which is prehabilitation and pre-treatment interventions. This is about having that conversation sooner, but about then making sure we're signposting, empowering the patient, and the whole purpose is to improve outcomes. So not just to deliver information in the form of some leaflets, but to really look at what would that person need to become as fit as possible, as healthy as possible, to cope with the treatment and to actually have better outcomes at the end of that. It's making full use of a teachable moment to make those healthier lifestyle choices. So when somebody's faced with a possible cancer diagnosis or an actual cancer diagnosis, we call it that teachable moment because that's when they're most likely to want to make some of those lifestyle changes to really reflect on perhaps, aspects of their lifestyle that could be healthier. And we really need to repeat that message as often as possible. I've got 3 questions. I'll just ask each one in turn and have a pause for people to be able to just think about that and put their answers on. You could also use the chat box function for that, or if you'd rather not use either, just really reflect on the question and think about what your answer would be. So is prehabilitation just for patients who are having surgery? It's a very simple yes or no on this one. Jo, have we got some answers there on Slido?
Hi Claire, just the one answer, and that was a no.
Okay, super. And I don't think I've had anything come up in the chat there either. So I'm hoping the rest of you just thought about that. So prehabilitation as a title, as a term, we've often talked about just for patients who are having surgery. We often associate it with pre-surgical interventions, but actually prehabilitation is for all patients. And that's why on the previous slide I've actually put pre-treatment intervention as well, because I think sometimes when we're discussing this with different teams, the word prehabilitation can conjure up an image of what that might be. So pre-treatment interventions, I think, is a little bit more all-encompassing. So this is for patients who are having surgery, radiotherapy, chemotherapy, any treatment intervention, or actually no treatment intervention, you know, who may be on watch and wait or best supportive care. There are still such benefits to making some lifestyle changes. Next slide, please. So what prehabilitation advice is the most commonly given? So this was from a piece of work that Macmillan did, and they looked at all the evidence and all the documentation. So is it A, dietary advice, B, physical activity, C, psychological well-being, or D, smoking cessation? So I'll be interested what people would think would be the most commonly given advice currently. And I'm not sure if that one person that you've Slido before wants to use it again, or otherwise if you just consider the question. Joe, has anything popped up on Slido there?
Just the one again, Claire. So it was dietary advice.
Okay, interesting. So I actually also would have gone with dietary advice, but it's actually physical activity, which I found quite interesting myself.
Oh, we've had another one, Claire. Psychological well-being.
Right. Right, again, now all of these obviously will be given in different to different extents, but according to the literature, physical activity was the most commonly given. But as we'll find out as I go through the presentation, they are all as equally important. Next slide, please. So just the final question here from me. Should we hold back on giving lifestyle advice or delivering interventions because of the cancer targets? So for example, your 62-day pathways. Is that a yes or a no? And Joe, you may just want to pop up there if you get any responses through.
So far we've got one, and that's a no.
Absolutely. I think this is something that when we do start to discuss prehabilitation or pre-treatment interventions, it is often a concern that, well, we don't want to delay somebody's treatment by having these conversations or by starting somebody on a you know, perhaps a programme of interventions. But very much so when we're talking about cancer, we would never want to delay a treatment, but we shouldn't hold back on giving the advice or delivering the intervention. It should be done in parallel. So we should still start it and we do it in parallel. Obviously mindful we may have to pause, step off any programme if somebody's having surgery, but then we'd continue with that afterwards.
We had another 2 votes, Claire, and they agreed with the no as well. So 3
Wonderful.
people said no.
That's brilliant. Thank you. Thanks, Joe. Next slide. Okay, so this is just a very basic model of how we could look at prehabilitation or pre-treatment interventions, and it's mirroring the model that I showed earlier for personalised care, which is having this universal offer at the bottom for 100% of patients, having a more targeted offer for 30% and a very specialised offer for 5% at the top. And woven down the left is the areas that we have to be mindful of to deliver true prehabilitation or pre-treatment interventions. So cost, supervision and location. So a number of pilot areas across the country have started to deliver a targeted or specialised model of prehabilitation, but that has come at great cost. It has, you know, there's been a lot of consideration around location. It's often delivered in community settings and a lot of supervision with full teams, project managers, you know, quite a project. And we do have one such area in our region. I know South Tees were a pilot area and they did the PrepWell programme. But apart from that, I would say the rest of us are offering universal support, and that's to a lesser or greater degree in most areas across our Northern Cancer Alliance. This is small pockets of work where people may not even be aware that it is a pre-treatment intervention. It's kind of business as usual. So we really do have a lot of work to get from where we are now to be thinking about offering that more targeted offer or even specialised down the line. But we have to start somewhere, and that's where we should be starting to think about the universal offer. Next slide. So the components of pre-treatment interventions. This really has to take a multidisciplinary approach because we're looking at exercise, nutrition, behaviour, psychological strategies. You know, at the bottom there, this is actually taken from the same paper I was talking about where I asked the question earlier, where they looked at literature. So what interventions are included. So always we've got physical activity, often is dietary support and psychological well-being, which was what was answered on the questions, which is interesting. And then just sometimes it's all the remainder there that you can see on the screen. But I think it's this MDT approach that is really key to actually delivering on this, because I think we have to be engaged with our allied health professionals. This really is a whole team approach, looking at primary, secondary, community services, voluntary sector. You know, this really does bring a lot of people together to be able to deliver this. I don't think this sits with any one area in particular, and it's pulling together, you know, all the expertise that we have. Next slide, please. So this slide's showing some of the trajectories of the potential benefits from introducing prehabilitation. So we've obviously starting at the left-hand side there, we've got the pre-assessment, and you can see straight away that a patient will plateau with no prehabilitation, which we would expect. But actually the prehabilitation takes them above that line, above that baseline, to prepare them for any treatment. And you can see they're already at the point of a follow-up assessment. You know, after they've gone through treatment, we're actually keeping patients above that line. So where without prehabilitation, they'll have dropped below their own baseline, but actually we may have managed to keep them at the baseline, you know, through some treatment. But actually what's really interesting is beyond treatment. So the finished treatment, recovering from cancer, what happens then? So it's also moving from prehabilitation to rehabilitation. So it is a continuum. It continues from that point of first diagnosis right through and beyond treatment. So it's about lifestyle changes. OK, so the findings from the pilot sites that I mentioned. So as I've already said, the allied health professionals are crucial to the success of the models of intervention. In addition to the physical and psychological health outcomes, it can actually, cancer prehabilitation can reduce morbidity, increase treatment options, prevent hospital readmissions, and lower the direct and indirect healthcare costs attributed to cancer treatment. And I think that's really, really powerful when you look at what we could potentially achieve with the right support. One study showed it can actually reduce post-colorectal surgery inpatient stays by up to 2 days. It can reduce anxiety and depression, which are both linked with poorer outcomes. We'll get a reported improved quality of life. Can improve fitness levels after a cancer diagnosis, which again is associated with better outcomes. But it's also, you've got the multimodal versus unimodal. We know from a study in 2013 there that exercise alone cannot be sufficient if nutrition and psychological care are not taken into account. So this is about going back to that model where we're saying it's not just about always looking at one aspect. It has to be looking at the whole patient and what matters to them and what's important to them and what their needs are. And also patient engagement's a key factor. This is about making sure somebody is self-motivated. If they're not, how can we follow a coaching model? How can we best support each individual patient to have the desired outcomes that we're wanting? Next slide, please. So in summary on prehabilitation and pre-treatment interventions, this is about personal empowerment. This is about an individual feeling they have some control, they have some purpose. If they're facing a challenge of cancer treatment, we're actually preparing them. A lot of patients will report that period of time between diagnosis and starting treatment, they often feel a lack of empowerment. And it's about making sure that with the right information, the right support, the right environment, they can actually be empowered to know that what they're doing, the health behavioural changes they may want to make, will make a difference to their overall outcomes. It's about physical and psychological resilience as well, so improving somebody's well-being. It's about improving the resilience to the possible effects of cancer treatments, enhancing the quality of life. And also long-term health. So this is encouraging reflection on the role of health lifestyle practices. This is where we need to also work with our public health colleagues. So this is about, if we can, capturing patients even, you know, from the point of a 2-week wait where they may not get a cancer diagnosis, but they will have had that teachable moment. Can we actually enable and support somebody to go on and prevent a further health complication down the line because they've actually been supported and empowered to make some healthy lifestyle changes. So that's me coming to the end of a very brief overview of prehabilitation and pre-treatment interventions. If we go to the next slide, please. I'm going to talk very briefly about holistic needs assessments and care planning. So this is building further on the health and wellbeing information and support conversation. It's again about addressing all aspects of a patient's clinical and non-clinical needs. So this is part of our personalised care agenda, but what we do know is there's a lot of areas now where this is starting to become business as usual, which is fantastic. So this isn't just done by our cancer clinical nurse specialists. We've also got pockets of areas where this is being done by our Macmillan information centres. In County Durham, we've got Joining the Dots, who have facilitators who would deliver HNAs. We've got various organisations and partners who are supporting this agenda. And it's about continuing that conversation, going back and touching base and understanding what matters to that individual. But we've got to ensure the patient has a copy of this care plan if it's appropriate and that it's shared, which is where we come to some of the challenges with our IT systems. But it's not just a tick in the box. So we do gather these figures for COSDI reporting. However, it's about the quality of the conversation, not just has it happened, yet they've got a care plan. We do know there's lots of areas where there are really good quality conversations and they might not be able to, for whatever reason, put the tick in the box. So it's two-way. It's about making sure we're having the quality conversation and the patient's getting the right information and support. If we could actually go back 3 slides, this is a bit, sorry about the the toing and froing. We're just going to hear from Tina about what it feels like from the point of view of having a holistic needs assessment.
We went through the holistic needs assessment in the form of a checklist. All the possible support could be offered to me and we just talked through it and I ticked what I would like. We didn't have a follow-up, to be honest, and we had no agreed action plan, so my nurse didn't check up on me to see if I had altered my diet or increased my exercise or anything like that. We didn't have that kind of follow-up. At the time I was going through the holistic needs assessment, I didn't really understand at that point what support I would need. So it would have been helpful to do it a few weeks later once I really understood what the implications of treatment and life-threatening disease is. You really understand what you need. I'm not a stupid person, so it would have been helpful to have it again.
Thank you. If we could move forwards now to the treatment summary slide, please. Thank you. Again, some really powerful words from when I spoke to Tina about not just having a holistic needs assessment once, but really revisiting that as well. I think it's important. So final slide for me, I'm also going to touch on treatment summaries, again, very briefly, because this is one element of when we're talking about this domino effect of where one element really knocks onto the next. So coming to the end of this point, so we've had a patient, you know, come through, they've potentially had their treatment, they've hopefully had some element of pre-treatment interventions, they should have had holistic needs assessments and care planning. So now we need to make sure the summary of that treatment is actually available to the patient, to the GP. So following whether that's surgery, radiotherapy, systemic anti-cancer treatment, which could be chemotherapy or other therapies, that we know that's been communicated. That treatment summary should incorporate actions for both the GP and the patient. It should highlight short and long-term effects of treatment and signs of recurrence to be aware of. One of the challenges again with our IT system is making sure this is shared with the GP, with the patient, and we'd like to get to a point where it can be with other relevant parties as required. We know our patients move around different hospitals and different areas within our patch. But we've just recently, Hassan, who you're going to hear from shortly, has managed to get a specific Snomed code for treatment summaries. So when the treatment summary document goes through to a GP practice, a GP will be able to pull that up much easier. They'll be able to find it, identify it quickly, and really look at what's important to that individual patient. I've also put on the bottom here about best supportive care communication. We do have a regional personalised care working group, which is very well attended with all the project managers and lead cancer nurses in the area, and we had a very good discussion about best supportive care. So these might be patients who come through our system and for whatever reason either may not want active treatment or may not be suitable for active treatment, but go on to what we'd call a best supportive care package. We also need to communicate that really clearly to our GP practices and to our patients about, again, what the expectations of that are and what the patient and the GP can expect. So we did feel it was really relevant that treatment summaries are also used for these patients. So it's all that standard communication. So from this point, there are actually 3 possible directions now for patients. We've got the best supportive care route. A patient might move on to hospital-led follow-up or personalised stratified follow-up. And also then we've got the cancer care review. But first of all, we're just going to hear from Tracy Wilson. So thank you very much. Next slide, please.
Thanks, Claire. My name's Tracy Wilson and I'm the supportive palliative and end-of-life care programme lead for the Northern Cancer Alliance. But in my other life, I'm also the personalised cancer care lead for Northumbria Healthcare. So I've got my foot in both camps very firmly. Next slide, please. So you may be wondering why I'm here at this point in the conversation when there's so much else to discuss about personalised care, but hopefully it will become much clearer for you. Next slide, please. So I want to start off just by getting this lovely fella into your head. This was a gentleman who I saw as a palliative care nurse who was diagnosed within the last 4 weeks before referral with a metastatic hepatocellular cancer. He'd had multiple contacts with healthcare professionals over the last couple of months, and that particular week he was seen by the oncologist and his nurse specialist on the Tuesday, and they did an urgent referral to palliative care. I contacted him on the Wednesday, found out that he was seeing his GP on the Thursday, and arranged to go and see him as an urgent patient on the Friday. So I'm not going to talk about him anymore for a little while, but just keep him in your head. Next slide, please. So I think the first thing that we need to think about is, what is end of life? When do we consider somebody to be at the end of life? And there's so many different conversations had about this, and we use different terms to talk about patients. We say palliative. The latest is treatable but not curable, and that's for those patients who are have a diagnosis where they can have treatment and they can live for a long time, but we know they're not going to be cured, but ultimately will end up in palliative care and at end of life. Next slide, please. So according to the national guidance, end of life care is the last 12 months of life. To me, I found that very strange, because end of life to me was the last few days of life. But actually, as I've worked more in it, yes, I can see why we would consider it. And there are certain signs that you can look for in a patient who you think may be approaching the last 12 months of life. And that includes just becoming more frail. If patients have had multiple admissions to A&E in a relatively short period of time, that's always a flag. Increasing fatigue and losing that appetite. And that's not just for patients who have a cancer diagnosis, but is a general kind of guide for patients who may be deteriorating and coming towards the end of life. Next slide, please. So how do we personalise care at the end of life? Next slide. And what I would say is, it's absolutely everything else that we're talking about today. It's no different. It's about having those holistic conversations with patients, making sure that you are talking to them about what matters to them and helping them to make their choices for what they want from their care. The only difference is they're quite emotive topics. So it's talking about things like where people want to be cared for, where they prefer to die, and using what we have in this region as a care planning tool, which is the Decide and Write suite of documents. And that includes the Do Not Attempt Cardiopulmonary Resuscitation, which is really difficult to say. which I think just about everybody knows about, and that's the document which is a guideline as to whether somebody should be resuscitated or whether it's felt that clinically they would be very unlikely to survive and may suffer more harm from trying to resuscitate. Advanced decision to refuse treatment, which is a document which is the only legal document out of all of the deciding rights suite, and it has to be specifically worded because it's about patients making an absolute choice about what they would and would not want should they lose the capacity to make that decision at the time. And it has to be written in a certain way so it is legal. Emergency healthcare plans, which are used to plan for anticipated emergencies. So somebody who may experience a lot of breathlessness, somebody who is potentially going to have a catastrophic bleed, you can actually write a plan that includes what the person or the relative or carer can do to support them in that, what the healthcare professional should do, should they be called into the person's home, and also what would be advisable in terms of directing to hospitals. And the other thing is an advance statement, which is a document that's completed by a patient which just answers a few questions to help them decide what they want from the rest of their life and how they want to be cared for, the things that matter absolutely the most to them. The last thing that we use to support somebody is, in the region we have the Care of the Dying Patient Care Plan, although I'm aware that not everywhere uses this. It is very widely used within the region. And it is a set of core documents which include a medical assessment, a nursing assessment, and also a daily ongoing assessment, just to make sure that we are given an equitable and sustained level of care to the patient at that point in time. It is a core document, so it kind of flies against that whole personalising care aspect, but actually it is meant to be used alongside other documents that will make that much more personal to that person. So making sure that you've got the right care plans in. So there is a core nursing care plan, but obviously you can add other things in around things like tissue viability and positioning, and you make that right for that person. Next slide, please. So when should we talk about advanced planning? And this is a difficult question because it's a hard conversation to have with somebody. And I think a lot of people feel if we bring it up, that person's going to think that they're going to die imminently. And some people do feel like that. Next slide, please. But actually, you know, we need to think about whenever the person is ready, but it should be well in advance of those last few days. It needs to be something that is done, I would say, even in advance of that last 12 months. It's something that we can all do. It doesn't need to be for somebody with a serious diagnosis. It doesn't need to be somebody who is facing the end of their life, but actually we can all do that to make sure that if anything happens to us, because let's face it, anything could happen to at any given time, you know, our family have got advanced knowledge of what we would prefer, and it just helps with those decision-making conversations with between relatives and care professionals later on as well. But also it just ensures that as far as we can, we are being supportive to your wants and your needs. And it is really, really hard, but it's so essential to be open and honest about things, about diagnosis. It's about using words like dying and not being afraid to use those words. Because if we are kind of fluffing around the subject a little bit, then it makes it a little bit more awkward. So it is about just gritting your teeth and getting on and just talking to people and not being afraid. Next slide, please. And then, of course, it's who should talk to the person about this. Who's the right person to be able to talk to the person with this terminal diagnosis about what they want from the end of life. Next slide. So really it needs to be somebody that the person feels comfortable with. And if we're talking about an advanced statement or talking about advanced place of care or death, any health professional can do that. But you don't need to be a qualified health professional to have those conversations. If that person feels comfortable with you and is open to having those conversations with you, then there's absolutely nothing within them that can't be done by anybody. When you're thinking about emergency healthcare plans, it really should be a qualified health professional. But again, anybody who the person is comfortable enough to have the conversations with and who feels comfortable enough to be able to make those care decisions. So around, you know, the steps to take if somebody's really breathless and things like that. There's some really basic stuff there. It doesn't have to go into great depth and be really complex. For DNA CPR, it needs to be an appropriately trained professional. There's an awful lot of controversy around DNA CPRs, and there's an awful lot of misunderstanding around it. So the person who completes that document should be somebody who's been appropriately trained. They're completed an awful lot by GPs because most of the care that a person receives is at home, obviously. And some nurse specialists can be trained to do it, district nurses, hospital doctors as well. For an advanced decision to refuse treatment, because it is a legal document, it needs to be somebody who's really competent and appropriately trained to be able to do that, because they have to get that wording right to make it a legal document. Next slide, please. So if we go back to my lovely fella, and then we think about how he was in himself, what had been happening to him, and reflecting back on the personalised care interventions that he could have had. So this was a gentleman who lived alone. He didn't have any family. His support was 2 friends who came to see him really quite frequently and helped him as best they could, but also had their own things going on at home. So one of them had a son who was really poorly, the other one had a wife who was really poorly, so they were trying to split their time between seeing this fella and spending some time at home with the other people that they were supporting. He'd become poorly over the course of about a year, and had seen his GP quite a bit over that time. Had a really good relationship with his GP anyway, but that had increased sort of over the last year or so. And then from getting his diagnosis, he had been seen by hospital consultant, oncologist, a cancer specialist nurse, and his GP. And then in that vital last week, he had been seen by an oncologist, his cancer CNS, his GP, and then finally his palliative care nurse, which was me. Next slide, please. So he did have that good relationship with the GP, but there hadn't been any discussions, there hadn't been any advanced planning. He'd had a hard time, but had built up a really good relationship with that hospital team. But again, there had been no advanced planning. When I asked him what he was expecting from his care, he told me that he was being referred for radiotherapy because he had a bone met in his arm and he was getting a lot of pain from that. And once that had been done, they were thinking about chemotherapy. Next slide, please. So I was due to see this gentleman on the Friday afternoon, but I came to work to a message on the Friday morning to say that his friend was thinking about phoning an ambulance because he was really unwell. And I rang just to see what was going on, to see if there was anything I could do to maybe avoid that admission. And it was really obvious that he was struggling desperately at home. So I went out that morning. As I've said, he lived alone. He couldn't get in and out of bed very well, so he'd been sleeping in the chair, but then he was struggling to get up and walk to the toilet. He had a Zimmer frame, but you know, from the state of the house, things really were not going well. He was very fatigued and he was very drowsy, and as I was talking to him, he kept falling asleep, and my impression was that he was dying. Next slide, please. So then, going in as somebody I'd never met before, I then had to start having those conversations with him. I had no relationship with him. I was a stranger in his home. He was unwell. He wasn't taking half of it in. It was not an ideal situation. But it was really important to me to be realistic in terms of what he could expect. And I started the conversation off by talking about these expectations he had for treatment, and especially around chemotherapy. And I told him that I felt that at that point in time, he was not fit enough at all to have chemotherapy. We talked about how he was managing at home, and he recognised that he wasn't managing at home, that this was a Friday morning. Everything happens on a Friday, doesn't it? So he recognised that he wasn't safe at home. So then we talked about what he wanted to do. He wanted to go to the local emergency care hospital because he'd been there before and he knew the people there. That was what he said. So then we had to really think hard again about what that meant. So, we talked about going to the emergency care hospital meant that he would have to go through A&E, that it was unlikely he would even be on the same ward as he had been on previously. So he probably wouldn't be among people who knew him or that he had a relationship with. And then I had to say to him that I thought he was dying, that there were other options. And I felt that because we didn't have things in place for him at home, hospital probably was the best idea. But then we talked about the palliative care unit rather than actually going via A&E. So again, it was a case of saying, these are the facts. What do you want? Next slide, please. After a little bit of conversation, he agreed to a palliative care admission, and I got in touch with the North East Ambulance Service, who have got a fantastic end-of-life ambulance, who transported him through to palliative care within an hour. Unfortunately, the gentleman died on the Sunday, but at least I knew he was somewhere safe. But I still wonder about what would have happened if those conversations had have been had before I met him. Is it possible that we could have made a difference? Is it possible that we could have worked around his care choices rather than be left at the end of it with no option but to admit him? So really thinking about when we're talking about advanced planning, as I've said, we don't know when things are going to happen, and we don't know sort of when things are going to need to be put in place. And to me, he had an awful lot of contact from an awful lot of professionals who didn't really acknowledge to him the gravity of the situation that he was in, and then ended up in a crisis. And that is something that we really need to avoid. So I said at the beginning about, popping up somewhere a little bit unexpected, because really when you're talking about end of life, you think you come after everything else. But we wanted to talk about it at this point in the conversation, just because we want people to start thinking about having those conversations much, much sooner than we do currently. And that's my contribution. So next slide, please, Sue.
Hi, my name's Kath Jones, and I'm the project lead for Personalised Care. And next slide, please. And I'm going to talk to you about stratified follow-up. And there might be some people that are on this call who think that stratified follow-up is just personalised care. Next slide, please, Sue. And stratified follow-up isn't the be-all and end-all of personalised care. We need to ensure that all of the elements that Claire's been talking about and Tracy's been talking about are all in place, because these all have the domino effect. If they're not put into place beforehand, it will affect the stratified follow-up element. So it's really, what is personalised stratified follow-up? And it's the point when we come to when a patient's treatment has finished, and it's about having those conversations, again, conversations with the patient, to be able to decide what is their best follow-up that suits those patients' needs, but also to understand that if they are going to go on to a self-managed follow-up pathway, that they know that they are going to have rapid access into the service again, and that they have contact with their patients. Stratified follow-up and supported self-management is not about being discharged. These patients are still the responsibility of secondary care. Next slide, please, Sue. So here, there's lots of acronyms that we come across and lots of strap lines that we all relate to stratified follow-up. And I think we get hung up by all of the different acronyms, and are they the same? Are they different? Do they mean different things? The words that are on here and the acronyms here are about stratification. Next slide, please. So the first part of it is, it's the stratification that we need to have in the first instance. So this is about, what is the patient's follow-up going to be? It's about having that conversation with the patient and having a shared decision-making conversation between the patient and the clinician to determine how they should be followed up. Next slide, please. Now, we've got traditional hospital-led follow-up, and that can continue and should continue for a lot of patients. And because of COVID, we've got the situation where we're not having face-to-face, we're having more telephone or virtual conversations with our patients, or we're having FaceTime conversations with the patients. But hospital and the clinicians are very much still looking after that patient. It's not, they're not in a position where they can self-support themselves and not come back into hospital. They still need to have those connections with the hospital. So that's absolutely fine. Patients can have a hospital-led follow-up. Next slide, please. So now we've got PIFU. Leslie at the beginning spoke about PIFU. PIFU is a national programme. It's not necessarily just for cancer, it's for all kinds of follow-up for patients. So PIFU and PSFU, as we know it, is where we have had the conversation with the patient. They would be able to self-support themselves, because if we've done all of those interventions beforehand, we've empowered our patients, we've had the holistic needs assessments, we've done our care planning, we've had lots of interventions, prehabilitation, all of these elements are empowering our patients to know that they are able to self-manage their own care. Patients will need, in some instances, need to have some blood tests done, and we need to determine where those blood tests are going to be done. You know, if we talk about our breast patients, they are going to need to have their mammograms, but do they really need to come back into hospital to have a face-to-face appointment to get the results? No, it's not necessary, and we need to understand how we impart that information to them. But equally, we need to ensure that our patients, whilst they've been given all of this empowering information, that if they do have concerns, that there are robust systems in place that they can contact our clinical teams and get re-access into the services where it's appropriate. Next slide, please. And it's the best supportive care patients. These are patients, you know, Tracy's spoken about these patients, and Claire also. It's about these patients who are not necessarily on active treatment, but we can't lose them in the system. They still need to have that support channels to know where to get advice from, so we mustn't forget about those either. Next slide, please. So the national deliverables for the personalised care agenda for stratified follow-up is that we've got 3 tumour groups. We are to have protocols in place, which we have for breast, colorectal and prostate. For our breast patients, we have agreed in the protocol that whilst the national deliverables is for low-risk patients, we as a region have gone with all patients, all appropriate patients, because we, you know, these patients are individual, and whilst they might reach the protocol to say that they could be able to self-manage, they might not be able to be in a position to be able to self-manage, and that's okay to have hospital-led follow-up. So for breast, it's all patients will be stratified to supported self-management. and we should be trying to implement these protocols by 2020. We're now coming close to 2021, and we haven't been able to drive that as quickly as we'd hoped because of COVID. But we are stratifying some of our low risk patients, and work is ongoing. Colorectal and prostate, we've agreed that the protocol is for low risk patients, and we are working with our teams to be able to deliver this within our trusts across the region. And obviously I think that target will be extended for implementation. Next slide, please. So what's the benefits for the patients? If we've done all of the interventions that we've talked about, Claire and Tracy, we should have been able to empower our patients to be able to know how to manage their own care. We will have had the shared decision-making conversations about what's important to them and have a care plan in place. As I say, we've empowered our patients to be able to manage their own care and how to access the services where they think it's appropriate. And it's okay for the patients to ring our clinical teams. We are still there for them. They're still our follow-up patients. You know, less appointments. It's really, it can be really anxious for patients to keep coming into hospital, particularly when we've got COVID going on. You know, we are geographically spread region. So some patients, you know, if we're talking about Cumbria or in the Dales, a lot of patients have a long time to travel. It can spend, you know, half a day travelling into hospitals. And once again, it's about reducing those anxieties. But we also need to be mindful about, you know, when patients are having tests done, whether it's in the community or whether they have to come into hospital to have those test results. It's about how do we communicate the access to those test results. Next slide, please. So what's the benefits to the workforce? So obviously, the big one would be that we are going to reduce follow-up clinics, but that, you know, means that we might have more time to have more meaningful conversations for the patients who we are going to follow up in hospital, to have those meaningful shared care decision-making conversations, spend time to do a quality holistic needs assessment and making sure that if there are any issues with the holistic needs assessments that we are doing care plans for our patients. You know, and it's really important what is important to our patients and be able to have those conversations. We need to integrate more with primary and secondary care. So if we've done our treatment summaries, you know, the conversation that Claire had earlier, if we are putting in place these treatment summaries and we've got them digitalised, we can send them over to the GP, who can have the Snomed code and put onto their system, which is absolutely fantastic piece of work by Hassan. But it's also about the patient having a copy of that treatment summary, that they can reflect on that they're taking ownership of that treatment summary. We can the workforce is able to maybe carry out some more targeted clinics with patients who have more complex clinical needs. That would be fantastic if we could do something like that and utilise that time. We also need to be able to embrace technology, and that is coming. We know that it's coming, so we need to be able to understand how that technology can help us. And the other part is, if we've empowered our patients to be able to manage their own care, it also empowers us to let the patients go, because we really do need to keep some of our patients, and that's probably one of the positives that COVID's done for us, that we are starting to relinquish some of the that need that we have, and we can let our patients go. Next slide, please. So we'll come to digital solutions, and you know, we are coming into a digital age now, and but we need to make sure that we are confident with our digital solutions. So if we are going to empower our patients to be to self-manage, they are our patients, and we need to ensure that our IT systems have safety net and systems in place to be able to remote monitor where our patients are within the follow-up pathway. It's about giving our patients digital solutions where they can have a look at their health and well-being, to be able to visualise appointments on a patient-facing app, which we're working with a digital company who's produced one with us. But we also need to ensure that we have equality in all of this, the digital solutions, because if we look at our region, we know that we are digitally poor. Not everybody has a smartphone or a tablet or a computer, and those people who do have a smartphone or a computer don't necessarily want to go digital. They like to have paper copies of everything. So we need to make sure that if our paper systems are robust, then the digital can pull from the paper systems as well. So for me, as far as personalised stratified follow-ups concerned, it is one element of personalised care, and we need to embrace everything that is within it and make sure that all of those dominoes are aligned up so that stratified follow-up can work to the best of its ability for our patients. I'd like to hand you over to Hassan, who's our primary care lead.
Hi everybody, my name's Hassan, and I'm a GP and I'm the primary care lead for Northern Cancer Alliance in the personalised care work stream. I just want to remind everybody that there is a Q&A tab on the Teams, and through that you can ask any questions and raise anything that you may want further clarification on. But it's also a great way to generate a discussion and speak about topics that you may want to focus more on, or that we haven't quite covered, or anything else that you want to have a chat about. So please do try and utilise that Q&A section. I also want to say thanks to the other team for the excellent things that they've presented so far. As a GP, some of the things I'll be taking away from this is especially about the prehabilitation, and especially the point about reducing inpatient stay. And I guess it's, even though someone like myself who's immersed in personalised care constantly, there's always something to learn and to take away and to change your practice for the benefit of the patient. I just want to bring everyone's attention back to the golden threads that Claire mentioned, that go through personalised care, and those threads were workforce, shared decision making, IT systems, patient experience, communication, and equality and diversity. And I wonder whether you've seen in the presentations that we've done so far how those themes keep cropping up, and how important those themes are in different sections of personalised care. We'll be touching on them as we go through, and how they will and how they impact us over in primary care. So as I mentioned, I'm a GP, and for people that are joining us from secondary care, I'm going to focus predominantly on cancer care reviews, and this gives our secondary care colleagues, I guess, a rare insight into what happens in primary care. You know, a real look over into the dark side, as they say. Not many people who are in secondary care often see the inner workings of what happens in GP surgeries, and it's really important, because when we talk about the domino effect of personalised care, the transition from secondary care to primary care is incredibly important. Next slide, please. The cancer care review is essentially where the transition happens from secondary care to primary care. A lot of appointments, a lot of communication, there's a lot of interaction when patients are in secondary care, and when they move over to primary care, it's almost as though things change completely. And it's not uncommon for patients to describe this as almost, you know, going off the cliff, or it's also been described as the black hole syndrome, where they suddenly start to feel a little bit more isolated and somewhat more alone than they did when they were in secondary care. And this is something that we really need to address from cancer care review, because regardless of whether in secondary care or primary care, we want our patients to feel supported. Next slide, please. So we're going to start off with a quick question on the slide up, and this relates to the CPES 2019 that's just gone. Next slide, please. And one of the questions that comes up in the CPES is, within general practice, did staff definitely did everything they could to support the patient during treatment? And this is a really important question because it helps people think, could more have been done? Could more have happened from the primary care team to help that transition going through? And we're going to do a little bit of a quiz here, so everyone can go on to Slido shortly. Next slide, please. I'm going to give you a bit of a clue. The national average was 58%. I'm not sure how people feel about that. When I first saw this, I expected it to have been a lot higher, but that's a national average. Next slide, please. And again, I guess the question is, did we do better or did we do worse? I mean, 58% is as I mentioned, I thought we would have done a lot better. As it's important to think about how did we as an organisation, as a region, did we do much better than that? Were we worse than that? Next slide, please. And these are a couple of options. So if you on the slide, or if you select which one, whether you think that we did, whether we were better, whether we were worse, or how much better or how much worse we were. I'll give you a couple of seconds to choose that. Have we got any answers coming through yet, Jo?
Yes, Hassan, we've got two people that think it's 62%.
Yeah. Give you another couple of seconds, see if we get any more responses through.
Got 3 people all thinking the same now. Oh, and we've got 5. So we've got 5 people. 3 people think 62% and 2 people think 67.
Okay, dokie. So yeah, the actual answer is 62%. Now, yes, we did slightly better than the national average, but we could be doing a lot better, I think. And I guess the reminder of the question was whether the GP practice staff definitely did everything that they could to support. I think that kind of demonstrates why the patients can often feel that transition from secondary care into primary care can be so difficult and so challenging. Next slide, please. So the purpose of the cancer care review essentially is to support the self-management for the patient after treatment. Not only after treatment, but also after patients are discharged from care, for their supportive care, or even for care. But it's very important in that review that we discuss how we can personalise their care. Each person needs to have that discussion of what's important to them, rather than what's the matter with them. And that ties in really nicely with the work that our secondary care colleagues do in terms of the holistic needs assessment. That gives us so much information as to how we can personalise their care, how we can personalise their plan to make sure that we're giving them the best care that the patient needs, not what we think that they might need. At the end of the review, it's a support plan that we put together that is tailored around them. And in this way that we can avoid this black hole syndrome that patients often discuss, where they're coming to primary care and they just feel as if the support suddenly stops. And the golden thread here, as I mentioned, is patient experience. You know, we really need to make this experience better for the patients so that they have confidence in the treatment and the support that they're getting. Next slide. So I guess there's lots of things that we do discuss in a cancer care review, and I'm going to go into that in a bit more detail in the next slide. There's lots of templates that are available that we use in Macmillan, have producing templates, but there's a lot of variation in them regionally and nationally. So the Macmillan templates, which are national, have got lots of different sections that we discuss, but regionally some things are more important than others, and this causes a lot of variation in quality of the cancer care review. As a target, in the way that GPs that we track this is through QOF, and regionally we only meet 69% of patients that need a cancer care review that get them. So this means, almost, just a third of people almost are not getting their cancer care reviews after they're discharged into primary care. And again, the golden thread here is the IT system. Can we improve the way that our systems are working to improve communication, to improve the information that we're getting, so that these cancer care reviews, we can improve them in quality, so that they are fit for purpose, and they're giving the patient the best information that they need. Next slide, please. This is a quick schematic about what sort of things that we discuss in the cancer care review. And the important point here is that often the trigger is a treatment summary that Claire mentioned and spoke quite well about earlier on. Through the treatment summary, we get a vast amount of information that helps us tailor the cancer care review, but also gives us points to discuss. And some of the things that we discuss is the diagnosis, what treatment they've had, what treatment they're going to have, the medication reviews, assessing the physical and mental well-being, but also their social needs from the holistic needs assessment. And through all these different sections that we discuss is how we generate our personalised care plan. And you can see that this can be tailored and it can be completely different for two people with the same condition and the same diagnosis. And this golden thread is a shared decision making. This isn't a time for the GP or for anyone to be dictating to the patient of what we do. This is sitting together and discussing what's most important to the patient, and through that making the care plan that we can work towards it, make sure that we're meeting the needs of the patient. Next slide, please. So the next question that's going to be on our slide is when do we do the cancer care review? Next slide, please. So there's different times that are available here. So if you just want to select it, diagnosis, end of treatment, terminal phase, or all of the above. This is when I guess is the best time to do the cancer care review based on what I've explained so far about this. Anything coming through yet, Joe, on the slide up?
Hi, Hassan. Yes, we've had two responses. One is end of treatment and one is all of the above.
All of the above, okay. Give it another couple of seconds. Any more come through?
One more response who agreed with all of the above, so 75-25 split.
Brilliant. So this is a bit of a trick question, I'm afraid, because the answer is what would be ideal, so I guess the answer based on what would the ideal time to be done, and the actual answer is when it actually is done through QOF. Next slide, please. So, and I'm going to come to the answer in just a moment. So patients do see an important role for primary care at the point of diagnosis for the cancer care review, at the end of active treatment, when they're discharged from hospital into primary care, when if they get a diagnosis of cancer recurrence, and from the terminal phase of the illness. So those that thought it was important to have it all the above are quite right, that from a patient point of view, having this cancer care review or having some sort of input from the GP from primary care at these points are seen to be incredibly important. Next slide, please. However, through QOF, the way that we code and the way that GPs are funded the cancer care reviews, it's actually a patient reviews recorded as occurring within 6 months of the date of diagnosis. So it's linked predominantly to when the diagnosis was done. Now, from this, we have to ask, is this actually the best time based on what's important to the patients, based on when the GP can best provide the most information? Is diagnosis really the best time to be having this cancer care review? Is that really going to be, is it the best time for the patient? Is it the best time for the GP? Is it the best time for secondary care to be getting information over to GP surgeries? because really in that 6 months from the date of diagnosis, the time for the patient is incredibly busy. They've got lots of appointments with lots of people in different places. Is another appointment with the GP at that point, who may not have all the information or may not have all the results, is that really the best time to be doing this cancer care review, to give the patients the best support? And I guess another thing to reflect on is the timing of this one of the reasons why the CPES result was so low, that maybe that the support isn't best to be happening at 6 months. Next slide, please. NICE have recently done a consultation where they've spoke to lots of GPs and patients, and there's a proposal to hopefully change the way that we're doing cancer care reviews based on the CPES result, and also information from GPs where we thought that we could perhaps do them at a slightly different time. There's a proposal now to change it so that a discussion happens within 3 months of diagnosis about the support that's available from primary care, and for an actual cancer care review to happen, structure template at 12 months of diagnosis. Now, this would be much better for the patient, because very early on from diagnosis, there's a contact from the patient to the patient from the service. You say what sort of support is available, how we can best help at a time that's quite busy for the patient, and they're going to have lots of appointments and lots of other things going on. But at 12 months on, things will be slightly different. The surgeries will have had a lot more information through. There may not be as many appointments, and also we'll be in a much better position to work towards a personalised care plan for the patient based on their cancer. Now, the reason why it's still linked to diagnosis comes from the communication secondary care into primary care. There was a pilot done down in east of England which found that it wasn't easy to identify when the actual end of treatment was, whether that's through treatment summaries, discharge letters, clinic letters, and it was felt that there was a lot of ambiguity about when that was happening, and therefore it's thought to be better to be linked to the diagnosis as opposed to treatment summaries. However, we can see from what we've discussed so far that the treatment summary is such a key document that provides us so much information in order to do a quality cancer care review. So the importance of that shouldn't be lost. Next slide, please. So the next question is, who actually does the cancer care review? Next slide, please. And this is our primary care workforce. Is it the role of the GP, a nurse practitioner, practice nurse, or any of the above? So I guess the way to think about this is, who is it best from the patient point of view, and also from the practice point of view? Who would be the best, who does the cancer care, but it's also important to think who would be best positioned to do that. Anything come through yet, Jo?
Yeah, a couple of responses, Hassan, and both people say any of the above.
Next slide, please. But now this slide, sort of the golden thread here, is predominantly about workforce. At the moment, I guess it can be anybody within the workforce that can do it. But there's a lot of it's quite an emotive topic, quite a difficult topic. It's a cancer care review, and what we're finding is that at the moment it's majority done by GPs, and that's because a lot of our colleagues don't feel they have the skills or the confidence to conduct cancer care reviews. Now, down in east of England, I mentioned before, there's a recent pilot done where our nurse practitioner colleagues were given a one-day training update on cancer care reviews. Now, you can imagine sitting there being, discussing cancer care reviews for a full day, but that tells you the level of depth and understanding that people felt that was needed in order to conduct it. And following on from that, 74% of cancer care reviews were then completed by nurse practitioners in an appointment that lasted around about 20 to 30 minutes. When they evaluated, there was a 96% patient satisfaction. Now, what this goes to show is that with the right skills and with the right workforce, you can empower any of our workforce to do these cancer care reviews. It doesn't necessarily need to be a GP. The most important thing is the time that we give the patients, and often the GP isn't best positioned to give them the time that's needed in the cancer care review, as we've gone through the complexity and the different topics that we need to discuss. One of the other things they evaluated from this review was that what they got from the feedback was that they actually wanted to increase it to a 2-day training, because they went over such a large amount of topics, large amount of information was given out. And hopefully one of the outcomes from that is that they're going to release some modular training, which we as an alliance are working on, to try to roll that out to all nurse practitioners in our area, to try to help give them the confidence and the skills to be able to conduct these cancer care reviews. And again, the golden thread here is the workforce, that you want to see the right person at the right time. You know, there's no point seeing somebody that isn't going to, for example, if you see a GP for 5 to 10 minutes for a quick cancer care review, it's not really fit for purpose. And again, this could explain a lot of why the CPAS result was as it was. Next slide, please. And just going back to our domino effect, you can see how the flow of communication, the flow of the patient, how that works. That we get that from secondary care through the treatment summary, we get information into primary care, we can conduct the cancer care review, and then we can signpost patients on to other areas where they may get more support holistically and non-medical treatment through social prescribing. And the golden thread here is, I guess, communication. It's absolutely key and absolutely vital in primary care for us to make our cancer care reviews of good quality and making them fit for purpose for our patients, for us to have that communication through treatment summaries, through discharge letters. And one of the big important reasons why we pushed for a new Snomed code for treatment summaries was so that we can track them chronologically. That all the information that you need is in that one important document, and you're not filtering through, looking through different clinic letters trying to find that information. Next slide, please. I'm just going to quickly touch on social prescribing in primary care, and this is really important. This is something that's relatively newly been rolled out, although in other areas there have been really good pilots back in 2015 of how social prescribing can help in cancer. And essentially where it's going to provide the most support is in the practical social and emotional support for patients once they're towards the end of their journey, or they've gone through a lot of the initial part of the journey, when they sit and reflect about what they've actually gone through and what an emotional topic it is. And from a personal experience, when relatives of mine have gone through, when you're going through that busy period of having lots of appointments, it doesn't really hit home until you actually have that time to reflect about what journey you've actually gone through. And sometimes that's the most important time, when you need that emotional support, the practical support to try and help you get back on your feet and to think about life after cancer. All social prescribing companies have got the time to help build meaningful relationships with patients that take off from the personalised care plan, to look at what matters to them the most and to use those to help provide them the support to be able to reintegrate back into everyday life, whether that's work, whether that's volunteering, whatever it is that is important to the patient. It helps to support self-management through building confidence, skills and knowledge. And you can see that the social prescribers are best placed to provide this, because the approach that they go on is what matters to the person. And these things do take a lot of time. They take appointments over a number of weeks, a number of months, to be able to really provide the support that patients need. And really general practice and clinical team members like the GPs and the nurse practitioners aren't best positioned to do this. And there's a lot of funding, a lot of time and effort going into networks to go through and provide social prescribing and to upskill them. And as a Northern Cancer Alliance, that's something big that we're working on next year, to be able to give all our social prescribing colleagues a training to be able to feel as if they're empowered and they've got the confidence to deal with patients that have gone through that cancer journey. And as I mentioned, that's something that we're working on next, early part of next year. So that's something that I'm sure people will be seeing a lot more of. Next slide, please. What we have just now is a couple of patient experiences from when a study was done about their experiences of cancer care reviews and the transition into primary care. And I think this highlights some of the issues that patients can face, and I guess some of the the reasons why that we really have to focus and change the way that we're delivering cancer care reviews. So, Jo?
It would have been nice, either a call or offered me an appointment to come in. I think I would rather have the invitation, because sometimes people think they're too busy, you don't want to bother them. But you don't know yourself what you want and what you don't want. I think perhaps just somebody from the surgery saying, you know, we're here and we sympathise. I think I could have done with someone just to confirm that I'm a person, and, you know, a little bit of sympathy goes a long way.
Thank you very much for that, Jo. And I think these are really, really powerful messages that come through, that when patients make that transition from secondary care to primary care, they don't want to be felt to be just another patient with cancer. At the end of the day, our patients with cancer, they're people. They have needs, emotional needs, social needs, and often that they don't seem to be getting addressed. And this is exactly why that black hole syndrome happens, because suddenly they don't feel that support is there from their GP surgery, from primary care. And by having a better means of information out to primary care, better cancer care reviews, and by utilising social prescribing, I really do think that we can really enhance the patient experience transition from secondary care into primary care. And hopefully in the coming years we'll start seeing that number of 62% creep up, and it can be a real thing that we can be proud of in the Northeast. That's everything from myself with regards to the cancer care review. And I believe that next we're going to be looking at the Q&As. So if everyone has a chance, any questions that there isn't anything they want us to focus on, please do utilise that question box on the panel at the bottom, and we'll try our best to answer them. Thank you very much.
Thanks, Hassan. Sue, would you like to move to the next slide, please? Thank you. So we've got a question and a comment in the comment section so far. So one, we had a few likes to this comment, a very powerful presentation from Tracy. Thank you. I would absolutely agree with that. I think it's very hard to listen to that and not feel really quite moved in terms of that patient journey. And we've also got a question in here. Do you think a no-deal Brexit will have implications on the provision of personalised care to the cancer patients? If so, are there any backup plans? I think we've had a small chat amongst the team on this one, and we can't think of an area where there would be an impact. However, I think there are a lot of unknowns in terms of what a no-deal Brexit may bring. I think just to add on that point, a number of areas that we have discussions and some challenges is around GDPR, so sharing of information, you know, accessing information between primary, secondary care. So when we're talking about this flow of patient data, that's sometimes quite tricky. So I suppose that's an area that I'd like to keep an eye on. Whether there will be an impact or not, I don't think any of us really know what impact there may be on policies, but I can't think of anything tangible. But if anybody on the call can think of an area or has come across a challenge, I'd love for you to share that with us, because yes, of course, we would be making backup plans if we were aware. So thank you. So thanks for that question. We haven't actually got any other questions and answers in there. Now, I hope that means that we've answered all the questions you may have had in your mind. I don't know. But what I would say to that is, if there's anything you'd rather not put in the chat box, or something you'd really like to have a further discussion about, or if you'd even like us to come along to one of your teams, please get in touch with any member of our team, and we'll be very willing to take questions offline and help out in any way we can. So if we could move to the next slide, please. So final thoughts. So although I live and breathe personalised care, I think it's been really interesting to sit back and listen to the other team members talk through their presentations as well here. And I hope that what we've given you is a real view from lots of different viewpoints. So lots of different members of the team with a different approach to personalised care. And I think that goes back to where we're saying it's the golden thread running through everything. And if we've achieved nothing else, I'd like to think that when you go back to your areas of work, when you're discussing other work streams or other areas of change or innovation, I'd love for you to sit there and you know, really say out loud, have we considered personalised care and where that fits in with this? Have we thought about this from an individual patient point of view? That'll be really powerful. So just to reiterate, thanks to the whole team there. A couple of things highlighted to me, I suppose, was where Hassan mentioned the black hole syndrome. That's exactly where we don't want our patients to feel they are. From what Tracy was saying, the importance of having those open, honest, transparent conversations. I think that's quite a stark, you know, stark discussion that we've had there. And through to Kath talking about personalised stratified follow-up, very important, and I think that's the epitome of the domino effect, that when we're trying to roll that out, if we haven't empowered the patient from the very start, if we haven't got all the right documentations in place, if we haven't informed the patient, the GP at every you know, every part of their pathway, then I think it's really quite hard to expect a patient at that point to then go off and self-manage their care and their follow-up. Which is where we come back to this domino effect. Very quick reminder of the golden threads running through that Hassan also gave us: workforce, shared decision making, IT systems, importantly the patient experience, communication, equality and diversity, and not forgetting COVID. And I'd like to leave you with some words from Tina, some overarching words about personalised care from a patient's perspective. Thank you very much.
It's critical, really. It's a hard enough time anyway, and if you don't get that whole wraparound care, you just feel like you're a number and an inconvenience. So actually, it's essential. It's essential, personalised care.